I'm Andrew Kuykendall from Moffitt Cancer Center. I'm here with Dr. Angela Fleischman from UC Irvine. Today one of the talks I did was talking about disease progression and what that means within the setting of myeloproliferative neoplasms. This is something that we talk about a lot, not so much definitions, but how to impede disease progression. And I think it's clearly something that's aspirational for us to do clinically. But to do that, we have to understand disease progression kind of on the more basic science level and at different aspects of the disease. I think certainly we think about progression talking about from maybe myelofibrosis to acute leukemia or from ET or PV to myelofibrosis, but we probably should be talking about this earlier. And I know Dr. Fleischman has looked at potential ways that we can impact disease initiation and progression. And I don't know, what are your thoughts? What's the best way to go about doing this? And is there an optimal time? Is early in the disease really a better time to try to target this?
I think that early in the disease, or potentially even at the CHIP phase, would be the most ideal time to intervene with approaches that could potentially change the natural history of the disease. In terms of approaches, I honestly don't know what's best, but one thing that we are investigating is utilizing dietary interventions, in particular a Mediterranean diet, with the hypothesis that through diet, in particular a Mediterranean diet, one can lower inflammatory cytokines, and persistently reducing inflammatory cytokines could potentially blunt disease progression. Obviously, we're still doing clinical trials and really don't have discrete outcomes yet, but I think that this is really an important field to further investigate. Now, as came up as a very important question in the question and answer session, it was asked, what sort of outcome should we be looking for and how to design studies to address long-term outcomes in terms of progression? And we don't have great answers to that. One answer was trying to identify biological surrogates of progression or lack of progression that could be utilized in short-term clinical trials to inform our long-term outcomes. But I guess, what are your thoughts on utilizing, dynamic, longitudinal evaluation of, say, NGS sequencing as part of a therapeutic or sort of monitoring approach for predicting progression and outcomes? Yeah,
I think when you think about what kind of goes along with progression, and certainly obviously if you change from ET to PV or PV to myelofibrosis, that's clear progression, right? We know that is a progressive event. But I think there's these kind of like micro forms of progression, right? Allele fraction increases, additional mutations, additional genetic insults. We know those often correlate with progression. Even at the pathologic stage, if you start to see more hypercellularity, more atypia, probably things that are difficult maybe to quantify, but maybe can be seen. I think those things need to be involved in any of these trials. Like obviously we need more early interventional trials, and maybe the endpoints don't need to be clearly defined, because I think it takes doing multiple trials with a lot of translational work, a lot of correlatives to really identify these endpoints, and they should be incorporated in all of our trials. I think any ET or PV trial needs to start looking at how these interventions change what the bone marrow environment looks like, changes what the allele frequencies look like over time. And I think that'll be important. I think certainly the idea of impacting the disease early is idealistic from a certain aspect, right? This is the time where the disease is maybe most modifiable, I guess. But at the same time, there's concerns there with toxicity, right? You're not really willing to accept much toxicity early on. You talked about dietary or exercise or lifestyle interventions, which obviously have low toxicity, right? Lifestyle interventions would be good for most people, regardless of whether or not they have a pre-malignant state. But at the same time, I think when we think about potentially modifying, various targets, I think, are there any targets that you've looked at in your work that you think are particularly interesting early in the disease state, right? So we can always think about different drugs or different things like that, but as far as targets, what would you think we should be looking at?
That's a great great question. Based on my personal interest and my lab's focus, we've been focusing on inflammation. We've been focusing on TNF production by monocytes. We're mostly evaluating differences between MPN patients and normal controls, and focusing on whether derangements in monocyte production of TNF may be a predisposing factor to acquire MPN. I haven't really thought of, but thank you for bringing this up, haven't really thought of utilizing longitudinal evaluation of an MPN patient's monocyte, I guess you could say, activity and the response to treatment, and whether that correlates with progression or stability. But that's the best answer I can.
Yeah,
that's the best answer I can give.
Exactly.
I don't think there's a good answer here.
No, and I think that these are the kind of the questions that we need to think about, and the ideas we need to have is what do we follow over time to kind of know that we're hitting the target, right? So we have to, first of all, we have to show that the target matters, and then if we can modify it, maybe that has clinical relevance. So, interesting stuff, and I think hopefully we'll continue to have ideas that allow us to intervene early and really change the natural history of this disease.
I agree. I think bottom line is our approach to treating myeloproliferative neoplasms and monitoring myeloproliferative neoplasms is changing, and what we previously identified as our key targets for endpoints may be becoming outdated, and we may need to identify better markers and better outcomes, or better endpoints that really address long-term outcomes and disease progression.
Definitely agree.